Um, Thank you for the beautiful acknowledgement of the lands in which we work. One of the things I'm trying to do in my acknowledgement is to bring a piece of artwork or something creative by a First Nations artist. And I just love this picture done by Simone McLeod, and it's growth from love. And I think about this in working with complexity, medical complexity, and what families have to do to support their people as the illness progresses, as they adapt to the changes of things that happen in the person's body. So quickly, we're going to review the definition of serious illness. I think I'm talking to people that totally understand this definition and advanced care planning, so we'll not spend a lot of time here. Reflect on working with patients who have differing abilities to communicate, discuss some issues of inclusion, competency, and shared decision making, and then I'm going to provide a few examples of how I might communicate in a certain circumstance. So we know this. We know this idea of palliative approach to care, and this idea that serious illness. There's a high risk of death over the course of a year. We sort of think about that in terms of if we think someone's not going to live a year, we really got to get some advanced care planning in. And this talk really is about how do we help support the person that has different intellectual or verbal abilities to really advance care plan. We know that serious illness also can have a strong negative impact on quality of life and functioning. It can be very burdensome to the person or to his family. And of course, it contains all of these elements. I don't know if you've read this article, but I have referenced it a lot in the last number of year or two, because this idea of cycling conversations over time is absolutely essential in how we manage not only deepening prognostic awareness, but also promoting resilience in families and the person who has the serious illness. Because ultimately, all of our goal is to increase quality and decrease psychological distress, facilitating end of life decision making. And so when I think about this diagram here of this circle, this is how I enter in the repetitive, ongoing conversations with people and with caregivers as we make decisions. Again, I speak from the position of using the serious illness conversation pediatrics. So this idea that we're actually asking the parent or the surrogate decision making some pretty critical questions about their values and their preferences. And towards the end of the talk, I'm going to give some specific examples around how we utilize critical abilities and trade-offs a little bit differently than the guide does when you're asking directly. And as we know, the SDM guide is also very helpful in supporting conversation. So those are just references to that. One thing we do at Canuck Place that I think has been really helpful. We have a very diverse population of children with very, diverse genetic issues and complex health issues that are sort of, very rare, but also fall into zones in which we operate and provide service based on how they are physically doing. And I'm not going to teach you all about how we use our zones of health framework, but one of the things that we know is when a child's risk of deterioration or exacerbation is high, then we need to do advanced care planning. So if you have a patient in front of you that you think, oh my goodness, this is, yeah, we have the surprise question that we use, but we use this idea of the orange or the red zone. And the orange zone is that kid or young adult that sort of his care is the same every day. But we know based on the body function that they could tip over. So they have lung metastases, their kidneys are on the edge, they have a very bad neurodegenerative condition. These things help us know sort of trajectory or what we should be doing in this zone. And the other thing that we look at as medical complexity increases is what's the stability of the care routines? Are the caregivers having to suction every 30 minutes? Are the feeds changing all the time? What are the pain and symptom management doing? And so this idea of fragility and stability really help us in our conversations with families about where their children are at in the trajectory. This is just a quick slide around what is an intellectual disability, a developmental condition that causes significant limitations in intellectual functioning, such as reasoning and learning, and in adaptive skills like social and practical abilities that are essential. It's different than cognitive impairment, which is a broader term referring to difficulties in thinking. Approximately 1 to 3% of the global population has an IDD, including conditions such as Down syndrome, autism spectrum disorder, and various genetic disorders, which we often see present in the pediatric part of their lifespan. Despite increasing prevalence, life expectancy has tripled. So life expectancy has tripled. We're still not better at this. We still feel ill-prepared when a person with an IDD walks into our office and we see that they are deteriorating. We're not sure how to approach it. Research shows that there's often still issues around inclusion and inequities and discrimination. So I just want to lay that foundation. This is probably why people are here. It's like, are we doing a good job? And mostly we're not. So how do we get better at this? And I don't know if I have all the answers, but maybe a few. We also know good palliative care for people with IDD is made more difficult because we have a harder time distinguishing physical pain and emotional distress. Pediatrics has some pretty good tools for nonverbal children that I think, if you have a particularly difficult adult in your care that that you're struggling with assessment, we have some good tools that you could talk to. I think also on the other end of the spectrum for our dementia patients, there's some good tools around assessing pain and things like that. But we have to get better at that. We do know that IDD people receive less opioid analgesia, and we also assume that people with IDD are not capable of care planning. So these are all sort of things that create barriers. Palliative care specialists have limited experience for people with IDD, and yet we also have people that are expert in developmental delays and developmental pediatrics that know a lot about that, but have limited knowledge in palliative care. So how do we collaborate between these groups and be more formalized in that and support people and their caregivers? There's no evidence that people with IDD have less need for information about illness, death, and dying, or that arguments promoted in favor of open awareness are less valid. So we tend to not initiate conversations. We don't necessarily know how to enter into them, and so it doesn't happen. So hard, right? What are the concepts? What does this person who's in this photo, and all these photos are just from the internet, they're not any patients or people I know. What is this person's sense of where they are in their life? Do they understand that that their body is failing? Do they have a sense of what death is? What are some things that we can do to support and reassure and link and connect? And how do we make sure that we provide the best care, considering the disability, but not be using that as a barrier? People with mild IDD often indicate some awareness of the condition, either directly in conversation or indirectly by mood and behavior. marked uncertainty as to whether people with a profound disability know what's happening, and do they have, for example, a sense of when they get a new diagnosis, do they have a sense of what that meaning is, and how do we help them with their understanding or even assess their understanding? So I'm going to go with just a kind of a story to see if this can be helpful in our discussion. So this is, again, just a photo from the internet, but um, I have actually recently supported a young adult that used to be on our program and lives in Kelowna, and was supporting their end of life in Kelowna. Um, because of this whole difficulty of what is good care and what did this person understand. So I thought we would do this and hopefully generate some conversation. So let's say Dylan, a 20-year-old with leukodystrophy, he lives in a care home but spends most weekends and holidays at his parents' home. He has been twice hospitalized in the last year, requiring ICU support for respiratory support. So they have found that BiPAP has been a helpful thing and it's worked. Um, and however, if you need respiratory support twice in a year, we recognize that you're in that quote unquote orange zone or red zone where you're like anticipating virus season's coming. What are we going to do? Is this a time to have a conversation? Dylan also has some symptoms of pain. He's got some contractures and dystonia symptoms that have been hard to manage through his life. And this also affects his sleep. Interestingly, he also has chronic kidney disease. They've been monitoring his kidney function, and there's a recognition that he is, in pretty precarious territory with his kidneys. And you, the palliative care nurse, CNS, doctor, social worker, have been asked to consult and do some advanced care planning. Let's reset. We know aggressive care for patients with advanced illness is often harmful. We know this. This is why we want to do care planning. And, when we think about Dylan and he has 5 admissions to ICU, what would that be like? Is that aggressive care what we want? Would an end of life in an ICU setting be the best for his caregiver's bereavement? How do we sort of think about the balance of aggressive care with the harms in which it causes? So this is where, in pediatrics, we really operate from. And I use this slide actually when I talk about children's decision making and their right to know. But what I did is I added children and persons with IDD because I really, really foundationally believe that children and people with IDD have the right to understand, to the best of their ability, their condition and care. They have a right to know what to expect and anticipate. They have a right to share their preferences and participate in decisions related to their health. And they have a right to be involved in important decisions in meaningful ways, even when they are not the primary decision maker. We don't ask a 5-year-old whether or not they want the bone marrow transplant or not, but we do other things around what are their decision making in that process? What is their right to understand about what's happening to their body? How do we help them expect and anticipate? And what are the choices in which they can have? And healthcare teams have the responsibility to seek the participation of children and persons with IDD by respecting, to the extent possible, their developmental ability and express preferences. Okay, I'm going to stop there for a second. Any comments about this and what that might mean in your practice? And I can't see everyone, so I just love it if you just unmute and talk. Are patients coming to mind for you? Do you already sort of operate in this way? What are some of the things you do? You can write in the chat too. That's easier. Shy people. I'm going to keep going.
I have a question, Kamara, if
Yeah.
no one else does. I guess I was just wondering about how you go about assessing someone's understanding with an IDD, I guess, to even start. I think that's what's like stumping me to start.
Yeah, yeah, absolutely, absolutely. And I think, there's such a range of what the cognitive abilities or processing abilities can be. I mean, I've worked with children and young adults that are nonverbal, but have every bit of understanding about where they're at in their illness. So, how do you pull that out versus somebody that you recognize have never been verbal and probably don't understand future, but they do know now, right? They do know how their body feels right now. And how we assess that looks different. Um, so, we're going to talk about that. That's great. I know there's some chats, but I can't see them. So is there something you should read to me, Laura?
Yeah, I was just gonna say that Alex just commented saying that it's easy for us to get stuck on kind of the patient being capable or not capable in that kind of binary. And so she's just appreciating the mention of involving people in those conversations and decisions.
Awesome. I that you just totally read what I needed, Alex, because it's actually a dynamic of preferences, that it's not binary at all. So one of the studies that we're looking to do at Children's Hospital is to actually have these cards that we present to children and teens about their control of preferences. And so it's a range. So the first part is does not want to or cannot participate at this time. So this might be an infant, or this might be someone who is sedated because they're intubated. And the caregiver and care team informed decision, right? So that is one end of the spectrum. To the other end, wants to choose and have agency with the decisions and is empowered to do so. And there's these three things in between that I just love. I've had teenagers say, I don't want to hear anything more about my cancer. I want the parent and caregiver to represent me and then share the information with me later. Or I want to share my view with my parent or my caregiver, but I don't want to be included in these long, drawn out conversations. Or I want to be included in the conversations and I want to be involved in the decisions, but I need my mom, I need my aunt, I need my grandfather to help me with those decision making. And all the way to wants to choose and have agency. And when we actually look at it like this, it gives us so much more meat and potatoes around what we actually can give them control over. And it also allows us to at least consider their view. It's not binary. Are there situations that you want to make a decision in? I.e., do you like your morphine by your mouth or sub-Q? That might be a decision, a medical decision that someone with intellectual disabilities could make a decision on. These are the decisions, legal and otherwise, that you can't make, but we would love to know if you have preferences around that. So the whole idea of the trusted and legal supports, I'm not going into all the details of all of this, but when we have, because I work in pediatrics, we often, and if there's divorce or if there's foster parents or if the state is involved, we have to figure out who the legal decision maker is. And this is very true for adults who are in care. You got to find it out and you got to get the paperwork. And this, I don't know if anybody on here can relate, but this can be a tedious process. You've got to find the paperwork, you've got to find that. But you also have to look more past the legal and say, who actually understands their day-to-day care? And it might not be the legal decision maker. It might be that nurse in the care home, or it might be the care aide that has been working with them for the last 7 years that goes into the home. So chart this, explore this before you meet with the person. Who can translate and communicate two ways with the person in the health system? Who needs to be in that meeting with you when you start to look at advanced care planning? And who sees the big picture of their quality of life? And who sees the details? So these are questions you need to bring forward in your care to really start to think about and explore. This ask, repeat, this model of breaking bad news, I think it's, we've all done this. We've done this work before. Ask, repeat, and clarify, check level of understanding, and help person to express feelings. This is really kind of what we need to do. The thing that sometimes we add in for persons that are nonverbal or differently verbal is to use photos and books. One of my colleagues, Dr. Amy Maybe, drew the best cartoons and diagrams for children so they understood, for example, how pain worked in their body. Instead of thinking that the pain was something they did wrong, how do we combat the pain? In this particular one, she used superheroes because he loves superheroes that were going to go down and get these pain villains to help. So really think about ways in which you can understand the person and then use their context to help describe what's happening. And I think we all know this, breaking difficult news should be done with familiar carers and this work with them in helping them. So yeah, find out what the person and their team already knows, straightforward questions, ask them what they want to know, speak to their experience. I often will say to children, what do you think is happening in your body? Why do you think your arm doesn't work anymore? So thinking about language that really puts it to their function and what's happening with their body. Providing clear choices is really important, but not going too far in the future. Often, if there is processing in intellectual issues, future thinking is actually really hard. Use assistive communication. There's a beyond words is an example, but there's other ones that you can Google. And encourage expression of feelings. I always talk about with caregivers the idea of legacy and life review opportunities to create a bonding with the person who we know is deteriorating. And this is a beautiful way to sort of, particularly with people that are nonverbal, is I encourage caregivers to say, tell me about when you were, tell me when Alex was born. What was that day like? Why don't we talk about that with Alex? Tell me all the things that you learned from this guy. What did he teach you? And this opportunity to do life review and legacy with people who cannot express their legacy, they cannot express their life review, but they need to hear it. That connection and bonding can be a really powerful intervention. Particularly around the time of progression, function change. So here's some advice, take it or leave it, but this idea of widening your lens, adult providers are often used to talking to their adult patients and figuring out what the adult wants. But we have to include the patient and ensure the right decision maker and the caregivers are involved. I love getting the insights of care providers that are non-parent. I love getting the parent's perspective too, but finding out what other people are seeing in this is really important. Book more time. I think that's a big one. Review and consider trade-offs. What makes a good day and what can't be tolerated? Use the wish, worry, wonder, and provide guidance for letting go of unrealistic or harmful or distressing regimes. So a couple of years ago, we sort of revamped the critical experiences when we asked parents about critical experiences for children, or when we ask kids of varying ages what a critical ability is. It doesn't land the same way as it does again in a functioning adult that's having losses related to their disease. So some of the ways that we frame critical or essentials experience, what are some of the things he really enjoys now? What makes a good day? If you had three wishes for your Dylan, what would they be? What would Dylan's three wishes be? And what comes from this often is things like, well, Dylan would never want to go back to ICU. He hated the BiPAP. And this is how I got to stopping admission to ICU for a young adult that we cared for a long time. The mom said to me, when we go to ICU, she said, my son we always raised him to not feel like he was failing things. He went to school. We never wanted him to feel like he wasn't as good as the other kids because he was nonverbal or in a wheelchair, couldn't do basketball the same way. And she said, when we go to ICU, I think he thinks he's failing and he is disappointing us. And I don't want him to feel that. And there was this place where I could offer my recommendation that we didn't go back to ICU the next time. And then we escalated comfort care at home. So instead of what directives do you want? What's your level of care? What's your M designation? What are your three wishes for Dylan? And what do you think Dylan's wishes are? This will get you to a place that can be really helpful in giving advice. And trade-offs is another one. I am assuming that everyone on this video or this meeting knows all about serious illness conversations. So I'm just going to go with that. But for the trade-off question, again, we made some changes for the pediatric guide. Because often when we say, what are you willing to go through for the possibility of more time? Parents are pretty much willing to put their kid through almost anything. And that is not necessarily helpful to the child nor the parents. So the way we ask about the trade-off question is, and we've learned from the research that saying setback is a very good way for parents to integrate. They see that because they often have had medical complexity for a long time. If he had a setback, what are some of the things you think would be worth trialing to see if he gets better? What are some things that you feel would not be a benefit or may do harm? I always remind adult providers that when you have young adults that have come from the pediatric system, that you're going to face resistance around not going back to ICU if they've had previous experiences of ICU that have worked, right? So that is something to be expecting. If you're going to trial some pretty aggressive care, having endpoints is really important. Sounds like you really want to try for non-invasive ventilation again. If Dylan does not show recovery or finds the treatment intolerable after 3 days, let's talk again. So you can see how this allows for that cycle of communication and prognostic awareness to continue. It's not, do you want to do everything or do you want to do palliative care? It's not that. It's something very different.
Yeah, I just have a question, Kamar, just because I saw something in the chat that I think slotted in maybe well to the trade-off section, which was from Amanda, who asked, if what if the person who has an IDD wants to choose something that isn't necessarily going to give them the most comfortable or safe palliative care, and kind of how is it determined on what course to take in that situation? So I thought maybe this trade-off section was a good place to ask that.
Yeah, that's a good question. So again, I think it's a dynamic communication conversation. Tell me what you think will happen when you choose this. Can I tell you what I think might happen if you choose this? What would be some of your hopes if that treatment didn't work? Where do you feel safest? Having the legal caregivers uh, care agreement come alongside with you and ultimately making recommendations that are grounded in what is good care and what is not good care. So we can say intubating your child or intubating a young adult that has a progressing brain tumor is not going to be of benefit because it's not the breathing that is the problem, it's the brain that is the problem. So how you explain that to someone with differing mental capacity, you may be able to get some of that through. But ultimately, we're not only looking at the person who is sick, we're looking at the people who are going to be left to be grieving. And how do we care for that whole ecosystem? And sometimes this takes many, many conversations. And sometimes we have caregivers that push and push aggressive care, even though we suspect the person doesn't want that. So how we work together on that, consulting ethics, having people with extra communication training, consulting, other people is really important. So this treatment decision piece, defining risks and burden of treatment, I think is something we have to think about. Will the treatment be understood? Can the patient comply with the therapy, or restraints or sedation be needed? Will treatment result in undue pain, suffering, and fear? How will quality of life be different after treatment? For some, importance of routine, familiar environments, even transfer to a medical facility could be very stressful. Will remission or benefit be sustained long enough to warrant duration of therapy? So these are the contextual questions that we need to ask when we're offering more chemotherapy, when we're offering BiPAP or yet another respiratory intervention that they have to somehow manage in a care home. Will this young person, will this 50-year-old man tolerate BiPAP? So it might be recommended by respirology, but this person, and he doesn't like Band-Aids on his arms. So how will we put a mask strapped to his face? So we come into the position where we're advocating for the person who might be nonverbal or differently verbal. We are advocating for treatments that align with what they can tolerate. It's recommended that we don't use the word futility or language that seems to undervalue patients' life. Parents often will comment that when they have a child with an intellectual disability or a nonverbal, that they can feel less than in the healthcare system, that their person doesn't have the same rights as someone that is fully, able to make their own decisions. And then that whole thing, and again, I think I'm teaching to people who already know this, don't ask, do you want to do everything? Or offer treatments you're hoping they refuse. I do see clinical teams do this. You don't want dialysis, do you? Not a helpful way to ask the question. So back to Dylan, these would be maybe some things that I would make recommendations. So this Dylan was offered peritoneal dialysis for his failing kidneys, or any dialysis for his kidneys. I might say, given how much Dylan dislikes time in hospitals and then he cannot tolerate tubes in his arms, I'm not recommending dialysis. Dylan's underlying condition is also worsening. His leukodystrophy is changing how much he enjoys his day to day. His brain is getting more affected, his body's more affected, and time in hospital or doing things for him he dislikes would take away the good days he could have. What I am recommending is giving him the best care as his condition progresses, which includes the following. I think we should do intermittent blood work. It's helpful to know where his kidneys are, and that might give us a bit more of a timeline. But we also want to have medicines at the care home that are going to be helpful for the nurses to be able to give if he has agitation or if his kidney function is bad that he has a seizure. We want to make sure we have those things in place. We also want to make sure that he has documentation so that people don't do things to him that won't be helpful. So we do want to know CPR order for him in the care home so that if he deteriorates quickly, you get to hold him, you get to comfort him, and you are not interrupted by people who are going to do the wrong thing. And I'll stop sharing. And hopefully there's questions or thoughts or disagreements. I'm for it all.
Thanks, Kamara. I can just start with another question that came up in the chat from Tamara, who had a question about suggestions for respectfully navigating the person with IDD's choice when it's not aligned with the legal decision makers.
Yeah, so I guess what I'm imagining is that this person has some verbal abilities and is sort of thinking, I want certain treatment, so to be more aggressive in treatment, and the caregivers saying they don't think it is a benefit or not sure they can do it or they're exhausted. I mean, there's definitely those places where caregivers just can't do another thing. So I often will say, let's have a discussion separately. I try and pick apart using, communication strategies similar to the guide. What is your understanding of what this treatment is? What are your hopes of the treatment? Why don't you want him to have treatment? Why do you want to have the treatment? And really separate it out and try and have those conversations separately. And then bring it back in together. And, sometimes I'll do like a list, and try and have them like this and say, what are the things we agree on first? What are all the things we agree on? Where are the points that we don't agree on? And where are the stopping points for things? In a serious illness, at some point, whether for any person, you become unable to talk for yourself, to speak for yourself, right? So as you get sicker, at some point, you're not able to speak for yourself. So I often realign the agreement. So yes, you're doing aggressive care and this person's wanting this thing and we're kind of going with it because we honor that person and we're trying to support the legal caregiver. But we're also trying to create a bigger connection for them so that that trust builds and that we reaffirm again with the person who is the best person that makes decision. Who do you trust? And so that there is if care goes down the direction and it's not working, that we're reaffirming that there's a decision maker that can support that. It's easier for me to have a very specific example and see that, but I think that the general theme is find out from each of them what they understand and try and bring them back together to connect. Adding in other family members or caregivers can be helpful, and adding in other professionals can also be helpful. Any other questions or thoughts?
situations to unpack. We know people are calling in from a variety of care settings today, so would be happy to hear about how this could apply to yours or whatnot. And then also, Kamara, we just got lots of comments saying that the Wish, Worry, Wonder framework is really helpful. People use it and seem to really like it.
Mhm. Mhm. Yeah, oh, wait, go ahead, Jacinta.
I couldn't find my unmute button for some reason. I think just something that comes to mind is when I was the coordinator for advanced care planning and most for Island Health. I'm in seniors health now, but at that time, I remember receiving a call from someone who was really concerned. They worked in a group home setting where someone with an IDD was living. They had a life-limiting illness. And their most, I believe, was an M1 or an M2. And the person's was very unwell and said that they wanted to go to the hospital. The group home called the ambulance, and the ambulance came and said, no, they must have been an M1 because they said, no, this is an M1. We're not transporting them to the hospital. Despite the fact that this person was saying, no, I want to go, I need help, I want to be cared for in the hospital. Um, and this was a couple of years ago, and it still just really sits with me because it's hard to know how do you how do you counteract or push back against that so that the person gets the care that they're actually requesting.
Mhm. Yeah. Yeah, I mean it's interesting. I think for me, the M1 is a funny thing because the
Hmm.
M1 only works if you have a very involved palliative care team
Mm,
who can actually increase symptom management in the location they're at.
mm,
If they do not have a care team that can increase care, then they can't stay in that location. And I've worked with many a group home, and even if their intentions are good, they do not have the staff or the competencies in
hmm,
palliative care to allow for comfortable dying and symptom management in that location.
mm,
So I caution anybody who's completing most forms around the M1. If there is not a team involved regularly checking in, you should not be an M1. You should be an M2 so you can go at least to get to a place that can give you opioids. So I think, Jacinta, I think when I think about what you do with that and you're holding it is one, I think everybody is kind of trying to do what they're supposed to do, right? Ambulance is supposed to do what they're supposed to do. The care home was calling because they didn't know what to do, and so they were calling. But I do think there's ongoing work with paramedics and firefighters because they're often there first around what does a most form mean, what does palliative care mean, and how do we ensure that if they're making an assessment, they're not just going on the piece of paper. So um, I don't know if you have any pull with any of the ambulance service, but I think those are conversations that I think are really important. And I also think for any of us here, if we see an M1 on anybody's designation and we know that the team isn't very involved, then we should advocate to have it changed.
really good advice. Thank you.
Anything else? One thing I just want everyone to be aware, because you're all in adult care, is that if you have a young adult in your care, Connect Place does do consultations and clinical support to clinicians, but also to families. We kind of have a loosey-goosey until they're 25, 20. But if you have someone that's never been fully independent because of their cognitive disability or their genetic condition or whatever that is, we are really open to receiving those hey, I got this tricky case around what do they understand and the surrogate decision makers. We are happy to walk through that with you. We have we have a 24-hour line. You can reach out to me, anyone on my team, to help you walk through that. We're very open to those conversations, and because we know there's a gap, particularly for those parents who never stop being parents to their child, and navigating that is quite different than someone in seniors care or someone who's lived a well life and then got sick. So just to say that we are open for any contact with that, and we want to work with you wherever you are.
Thanks, Kamara. Can you just clarify what the definition of a young adult is? Or yeah,
And
maybe.
Nicole just asked, what about someone with a degenerative condition as a young adult? Definitely, we go case by case, right? We go case by case. We've had 23-year-olds who have an advanced cancer that we never knew in pediatrics that we will support if they are dying. Like if we sort of see a prognosis, like we see. So there's neurodegenerative conditions that we know have a shorter, yeah, yeah, early 30s. Yeah. Locked-in syndrome, very, very hard. But again, that scenario is so difficult, and yet we do have similar circumstances that we've supported before. So happy to just even take a call and see if we can offer even just consultation with the clinician. Even sometimes around like what pain tool do we use, right? We might have a pain tool that might be really helpful for the parents to use the tracking because we are used to nonverbal, right? That's our bread and butter here. So, all right. Well, I think I'll give you your 5 minutes back. Is that okay,
Yeah.
Laura?
Yes, I think that sounds great. People probably have to get back, but thank you so much, everyone, for attending, for taking time out of your busy days to listen. Make sure to take that survey when you log off, and just big thanks to Kamara for providing her expertise and kind of extending beyond the pediatric world and sharing this knowledge and letting us kind of understanding how it can expand beyond for all people with IDDs and beyond. So thank you so much, Kamara. Really grateful, and stay tuned for the link to the recording, everyone, that we'll be sending out afterwards.